Optum RX 21%. So all total, these three companies control 80% of all prescriptions nationwide. If you get your prescriptions through a health insurer or through Medicare Part D or a large employer or any number of the different Cigna, for instance, actually is associated with Express Scripts, I think it is. So basically, the PBMs develop and maintain formularies for the in health insurers, and that includes Medicare Part D, who contract with them. So the PBMs actually develop and maintain the formularies of these medications covered by a health plan. They track claims processing, and they determine, actually through their negotiations, what the out-of-pocket expenses are going to be. So basically, PBMs use their purchasing power, their group purchasing power, to negotiate rebates and discounts from the drug manufacturer. And they also, PBMs also contract directly with pharmacies to reimburse them for the drugs that they dispense to the enrollee. So that's just kind of a short story about what PBMs are and what they do. So next slide then, Mike. Go back one. So as you are probably well aware of, there are controversies about PBMs. So there's three main players in this whole thing. There's the drug manufacturer, there's the enrollee, us, and there are the pharmacies. So those are the three primary players in this whole scheme of how medications make it around the nation into enrollees' hands. So each year the PBMs negotiate with the drug manufacturer regarding how much they'll pay for a particular drug, and they negotiate with the pharmacies how much they're going to reimburse the pharmacy for selling a particular drug. So just to give you an idea of the money that's being, oops, could you go back, Mike, please?
Yeah. It's doing its own.
So just as an example of what kind of dollars are involved in this, so the PBMs, as far as negotiating rebates to the manufacturer, those rebates to the manufacturer have increased from $40 billion in 2012 to $90 billion in 2016. So this is all part of why prescription medications cost so much, because the PBMs determine what they're going to rebate back to the manufacturer. And each year it goes up. There's also what's called price spreading, and this has to do with where PBMs are paid by health plans like Medicare Part D so the PBMs get reimbursed by the health plan and the large employers at a higher price than for generic drugs than what the PBM pays to the pharmacy, what the PBM reimburses to the pharmacy for the medication. So this is called the price spread. And this is a completely opaque, non-transparent record keeping that I don't even think CMS has access to. This is part of the controversies with PBMs. And another highlight here is that the PBMs profit more for the more expensive drugs, so the non-generic drugs in the formulary. So they make more money on the more expensive drugs. So you know, a health plan might really favor more expensive drugs because that helps feed the system here, basically. Okay, so if you can go ahead to the next slide. So the next slide is, I'm afraid, sorry, a little dark, and it's a little too small to really see the big details. But the upper right corner is, I'm going to have to look at my slides because I can't see that from here. So the upper right corner, that orangey kind of box, is the enrollee. So that's us, any of us who have Medicare Part D, we are in that orange box. In the upper left-hand corner is CMS, and in the gray rectangular box, that is the Part D plan. So when we have Part D, we have to sign up with a particular provider health plan, basically, and that's what that box represents. And then going down the left side, that next gray box is the PBM, actually. If you go over to the middle gray box, that's the pharmacy. And over to the right is the wholesale distributor for the medication. And then the bottom gray box is an actual drug manufacturer. Okay, so the three main players in this whole scheme are the enrollee, the drug manufacturer, and the health plan. And the PBM is what manages all of that, basically.
We really don't know the flow amounts. Yeah, this is David Ladwig. We really don't know the flow amounts in any of those flows. So it's really not as straightforward as this. And this is only the one where, of course, CMS is involved. So if it's direct with a large employer, if it's direct with the insurance company, not CMS, it's slightly different. But we don't know any of these flows.
Thank you, David, and for that additional information. And again, this is the lack of transparency issue that is a controversy in the PBMs managing all of this. So in the dotted line, if you can see the dotted lines with the arrows on the end of them, that's how the money flows. Okay, so the dotted lines with the arrows on them is how the money flows. And the solid lines with the arrows on it, that's how the product flows, right? So if you go down to the bottom gray box, the drug manufacturer, you see a solid line going up to that right gray box, which is the wholesale distributor. And then there's a solid line that goes right across to the middle gray box, and that's the pharmacy. So that's the product flow. That's how the product flows. And then from the pharmacy, there's a solid line goes up north there and then makes a right-hand turn and then goes up north to the orange box. That's the product flowing from the pharmacy to the enrollee Okay, so that's kind of the way that this all works. Any rate, I think we'll leave that confusion as where it is and not try to confuse it any further. Okay, so next we will go to the next slide. So GoodRx, so when I first started using GoodRx, I believe it was like 2012, I found out about it and started purchasing what few prescriptions I had at that time, actually, it was like 2. And so they started as a startup, and then if we can go to the next slide. So this is similar to the diagram where Medicare Plan D was involved, but it's different. So all of the information over there on the left with the arrows and the dotted lines and the solid lines, that's all very similar to what Medicare Plan D is involved with, as well as multiple other health insurer companies that contract with these PBMs to get medications to patients. What's different in this is over to the right, there's actually a second PBM manager. And I don't know if you can see the kind of the black image right there in the middle between the first PBM manager and the second PBM manager. That's the discount card holder. So that's where GoodRx would be. That's where Blink Health would be. That's where ScriptSave WellRx would be. That's where Single Care RX will be. That's where Optum Perks will be. That's where Walgreens will be. That's where Humana will be. That's where America's Pharmacy will be. It'll be in that second PBM icon there. So at the same time, these discount card outfits are getting medications to people at a lower cost. They are still extracting money from the system, which contributes to our prescriptions being so much higher. An important distinction between the PBM Manager 1 and the PBM Manager 2 here is that the PBM Manager 2 really deals primarily with generic drugs. They don't manage, it's hard, you don't get any benefit with going to GoodRx and getting a brand name drug. You only benefit, and as an example, one of my more recent medications, if I use my Plan D benefit, monthly cost of that is close to $500. If I use GoodRx or any of these other discount cards, it's $16 a month. So that's gives you an idea. That's kind of back to price spread. There's this huge price spread, which there is no transparency around, so who knows what's going on in there, but that is an example of the benefit of the discount card. If you're on a brand name medication and there's a generic form of it, using one of these discount cards is greatly to your advantage financially. Okay, so let's go to the next slide. I forgot what the next slide is. Okay, so now this is a link. This is a link which maybe we could send out in an email if people want to get into this in more detail, and perhaps even most likely have a better explanation than I've been able to describe to you. So we'll send that link out to you, but this is some information to that link. So for instance, and this is specifically about GoodRx. GoodRx and other discount card programs only apply to generic medications. We talked about that. GoodRx and discount card programs profit by incentivizing people to bypass their own plans' out-of-pocket costs and PBM rates in favor of a different PBMs rates, again, for generic drugs. So they make their money on non-generic drugs. So GoodRx just in the last 4 months, GoodRx has formed a coalition with Cigna's Express Scripts. So that's where kind of GoodRx has gone with their startup model, and within 14 years are now hooked into Cigna's PBM for Express Scripts. Okay, so next slide. All right, so this is the link to goodrx.com dashboard. And when you get to that, if you open up that link, you can see all of the pharmacies that GoodRx uses in your local area. You put in your zip code, they tell you all of that. And then you type in the medication that you want and the dosing and how many days. And this was for a drug called midodrine, which treats orthostatic hypotension, not hypertension, hypotension. And the cost through GoodRx is $31 for I forgot what I print in and put in there. I think that could be, it's either 30-day supply or a 90-day supply, one or the other. But at any rate, this is the web page you would get to type in one of your generic medications and see what the price would be if you just paid for it out of pocket versus going to your plan D, Medicare Plan D. This is where I discovered that this one medication that if I use my Plan D, it's $500. If I use GoodRx, it's $16. This wasn't the medicine I was referring to. It's just an example of a medication. Okay, so let's go to the next slide. So what has happened in January 1st of 2022 is that we have another option through OHA. It's called the Array RX card. And it's a discount card. It's similar to GoodRx. It takes the place of the Oregon, it's the OPDP discount card. That was the Oregon Pharmaceutical Drug Plan discount card that people had previous to January 1st of 2022. So this is another option. You can go to the next slide there.
Can we just make sure people can hear you still?
Are you guys hearing me okay?
Let me get Karen Ellis up. Try again. All right, thumbs up or down, Karen. Can you hear Bruce okay? Go ahead, Bruce.
Okay, you hearing me all right?
Okay.
Okay, cool. All right, so the Array RX card that you can go online to the OHA site and get registered for it. It's only for Nevada, Oregon, and Washington residents. That's all. So this is a separate PBM that serves Nevada, Oregon, and Washington. And it's, no, this is right off the OHA website, no membership fee. Also, I should say, it's this information is available in multiple languages on the OHA website. So that's another great advantage. So all FDA approved prescriptions are eligible. Each user signs up and gets their own. You can get a digital card, you can get a hard copy of a card. You have a unique ID number. If you have a smartphone, you can put all this information into your smartphone and show the pharmacist that, oh yeah, I have an Array RX card, so this is what this medication should cost. So you show your card to the pharmacist when you pick up the prescription, and it can be used outside of your prescription Plan B. So next slide. So this is the link to the OHA webpage about this discount medication card. So this is what you'll see, and down below the first picture, it says find your RX, and so you click on that, and it sends you to a page where you can type in your medication, and it'll price it out for you, basically. So we can go. So that's another website that we could send out, maybe in a mass mailing, or maybe post on Mid-Valley's website or something like that, so people have access to it. So what I found was that I looked up a couple of medications with the Array, and what I found was that again, you're looking at your local pharmacy area. So amongst all of the pharmacies in our local area, the price was pretty consistently the same. It was interesting, though, when I put in certain medications, some of the pharmacies in our area would not have that medication because they're not part of the Array RX system. So that's kind of curious. Anyway, and in looking at pricing for good RX, that it varies a little bit, maybe 10% amongst the local pharmacies for that generic equivalent of a name brand medication that you might be paying a lot more money for. Okay, let's see, David. Yes, thank you.
I think one of the problems with all of these things is you can't map it so that you can find it easily. So like the difference in price between two different pharmacies without checking them out individually, you're probably not going to be able to find that. And as far as all the different plans and all the different PBMs, like commercial insurance, Medicare Advantage, Medicare Supplemental, versus all these different ways you can potentially save money, it's not in any one place where it's all just, oh, I can go look that up, which is like really frustrating to people like me, because I spent 20 years working with health insurers, and 15 of that with pharmaceuticals, not all, but largely, and you can't look it up. You gotta do it drug by drug and possible discount by possible discount.
Yeah, so David's a data scientist, so he's looking for the mass data, and he's right. And this is part of the problem with the PBMs, is there's no transparency on that. So, an interested party from the public doesn't have access to any of that information. However, that's different from, like, if you're looking up a particular medication that you are interested to know the price for. When you go through either our Array or one of these other web pages, you put in the medication, you put in your zip code, and it will give you the prices for that medication for all of the pharmacies in your 5-mile area or 10-mile area. So yeah, it's not good for doing data analysis like what you want to do, David, and you're so good at, but it does make it is easy as an enrollee looking to save some money on a medication that you need to have. I don't think there's another, is there another slide? That's the wrong direction. Okay, no, I guess that's it.
Oh, Jenny got her hand up.
Okay, oh yeah, questions, I guess.
Oh, I just think it's completely unfair. This whole thing is so unfair for patients to have to try to navigate.
I can't
Is,
hear.
oh, whoops, you can't hear me? Come on, can you hear me now?
Can you, see, you're not muted.
Yeah, okay.
Can you, oh, there you go.
I can hear you.
Can you hear me now?
Okay, we're not hearing you.
I can hear you, Jenny.
Okay,
This is
do you
Linda.
want
I
to
can hear
translate
you.
for me?
I don't know if they can hear me.
And, everybody else here, Jenny? Kathy?
Mhm. Yep.
Oh. Oh. Well,
Jenny, maybe.
Will you
put your question in the
translate
chat
for
so,
me?
Bruce can see it. Because
What's
we
that?
can, we can't hear you.
I suspect Mike's computer is muted.
Okay, how about if can you translate for me?
I don't
I
think,
don't think you can hear
Mike,
any of us. that are
right,
on
I think his
Oh.
computer is muted.
Okay. All
Yeah.
right, well, I could try to type, I guess.
yeah.
Oh, no, we can hear you now.
We can hear
We
you
can
now.
hear you.
I didn't press the right
Oh.
button.
There you go.
Okay, now you can hear me?
Yeah.
Yes, yes.
Well, I just, so I'm a family physician and I take care of patients who need these medications, and I'm glad to hear about the Array, and I will look into that. I just think it's completely unfair to people to have to try to navigate it.
Yeah.
It breaks my heart that, that we're expecting people who may not have the wherewithal to do so. But it was just a comment more than anything. So.
Yeah, I feel your frustration because not everybody has a computer or the skills to use it to navigate. it.
Right.
Mm.
And so the GoodRx is a pretty easy app to use. Do they have for the Array? Is there an app for that?
Yeah, I'm pretty sure they have an app for that too.
Okay.
Yeah. And
Yeah.
And it does, so the health plans, are happy that.
Yeah.
They have, patients have better access.
So
Yeah,
they don't have to pay for it,
right.
right? Yeah.
Well, yeah, I don't know how that works.
They're still paying the bulk of it. We're only talking patient out-of-pocket costs. So the health plan is still paying a large amount for these drugs.
Not for the GoodRx. The patient pays completely out of pocket for GoodRx.
Right, correct. But in that, one of those diagrams, the health plan is, the money, where the money flows. I don't know if you can go back to that money flow diagram. Where the money flows is from the health plan to the PBM, actually. Because the PBM manages the formulary and the PBM negotiates the rebates to the drug manufacturer and the rebates to the pharmacy that they've contracted with for a given price for a given medication. So the health plan is, yes, they are paying for it. They save money when people move from a name brand drug to a generic drug of equal equivalency. I don't know if that helps, but
Which slide? Is the
this
next
one, yeah. So let's see, in this slide. So the, let's see, payment flow, okay. So payment goes from the health plan to the pharmacy benefit manager, which is, I did say that correctly. So I'm learning. So that's where the money goes from the health plan to the PBM, and then the PBM does give a rebate back to the health plan, but the value of that rebate varies from year to year, and I'm not even sure if the health plan, unless they keep track of it, if the health plan knows, you know, what the rebate's going to be next year. I hope that helps confuse you all, because then I feel like I'm just as confused as you are, but it's a very confusing schema, I would say, and it is quite a scheme.
Right.
I think Jenny was trying to speak again.
You're muted now. Jenny. Still muted.
Is she hearing you?
It still says muted.
Oh, just that, and maybe I'm speaking too much. Just that the Good RX has, you do not need to tell the pharmacy that you have any sort of insurance at all
That's
on the
correct.
Good RX.
Yeah,
It's completely different.
yeah.
And so the health plan doesn't help you at all with that.
No, but remember the PBM actually keeps track of all of the transactions. Because that impacts how much money the PBM gives back to the health plan as a rebate. The rebate doesn't ever go to the patient. The rebate either goes back to the health plan or it goes to the pharmacy. The patient doesn't get any rebate.
Right. Okay. Yeah.
No,
Nice.
the state of Oregon has, it just is now going into effect. They've been meeting for a year. Prescription drug accountability board.
Hmm.
But right now, they're also in the legislature trying to pass some laws to give that board more teeth. For example, there's a law to make sure all the PBMs that want to do business in or with the state of Oregon are registered. And then number two, once they're registered, that they have to provide the data on rebates and prices they're paying to the manufacturers and things. So you can understand that both the pharmaceutical companies and the PBMs are fighting this legislature.
Hmm.
But no one else seems to be opposed to it. But the prescription drug, that has real potential to save money, but they're only aiming for 10 drugs at a time. So it will really be probably 2 or 3 or 4 years before it really starts to have much impact.
Kathy Soward has a question or comment, and then in the room here, Alex.
I have a question, technical question. Can everybody see the close-up pictures of Bruce and David now? Okay, they fill the screen now?
Yes.
No.
We can see them.
Okay, but they're not filling the screen, right?
I'm on a rocking ship.
Bruce is bigger than me. Bruce
Oh,
is the
one
giant
more
mouse.
question. How about now? If I spotlight them, that's what it's called. Now,
Oh, there you go.
okay, all right.
I can
Thanks.
do that.
Thank you.
Okay, Kathy and then Alex.
Well, I was noticing when you showed the kind of tan background process flow before, I thought that is just full of, I don't even know what the best way to say is this. Every one of those lines is a cost. And so, and most of them have, well, I'm thinking they mostly don't have benefit. I don't know how the PBMs run. I don't know if at the beginning of their negotiation period, they say, we want to have a return of X%, and that's what they go after instead of, you know, what can we save our end users or something like that. I have no idea, but it just struck me as how much cost is in that diagram. And it's huge. There's not very many lines that have to do with product movement. There's a lot of lines that have to do with other things.
Yeah. Yeah, and remember that in 2012, the PBMs, the manufacturer rebates to the PBMs went from 40 billion in 2012 to 90 billion in 2016. And again, that's part of why medications cost so much in the US, because of those dotted lines going back and forth on that in that diagram. Alex? Yeah, right.
Thanks, Bruce. So quick question. Public versus private and profit versus nonprofit. I was just wondering, because that slide you showed had an OHA website for the Array RX. Are they just doing it as a public service, or is there any involvement with government, or is this all just strictly private and all for profit? I mean, are there any either public entities or nonprofit entities in all this, or is it all just profit driven from the get-go?
David? I mean, theoretically, and Oregon is trying to demonstrate this, government has the power to regulate PBMs. They would have the power to regulate insurance companies, and indirectly that way to get at pharmaceutical companies, because pharmaceutical companies for industry of their size, they are making like 3 times the profit as an industry of any other industries of their size and in capital and research structures. So everybody who's in it for money is doing pretty well. I mean, the state has the power to step in and do some of these things. But they're getting pushback from the people that would lose money.
Does that answer your question, Alex?
Sort of. So, but just to your knowledge, do you know, is there anything that's more publicly oriented in any of these organizations? I mean, were they all just profit driven?
Well, I mean, you know, we've talked a lot in Mid-Valley, this meeting and others about the single payer. And if it gets to single payer, where it's one payer dealing with, you know, 3 PBMs, then there could be more negotiations, and it can get closer probably to the true price of the drug. But all through healthcare, but especially pharmacy, nobody knows the true prices. Maybe the pharmaceutical companies have some idea what it costs to make, you know, 1,000 more units, but they don't make that public.
Okay, thanks.
Other questions, comments?
Need the mic.
Other questions or comments? If you can raise an electronic hand, that helps.
I have a question.
Okay, go for it.
What does that second diagram look like if you were in a country like France?
I don't think there is a second diagram in France.
Right, so there's no PBMs in France. So what would the diagram look like if we were to implement that kind of scheme in Oregon?
I think the government buys the drugs and they dispense it to people who need it, I think.
So that should be the diagram we should be proposing here, and not try to regulate the middleman. That never gets us anyplace.
I was talking, I was in Portugal for vacation in 2017. And one of the places we stayed, I ended up talking to this guy who was a pharmacist for Pfizer, but a pharmacist for Pfizer working in Switzerland. And he said, you know, people throughout the world are just incredulous that the US government won't negotiate with pharmaceutical companies, because the rest of the world, that's what goes on. The government negotiates directly with pharmaceutical companies. The pharmaceutical companies in the US make so much money on the excess profit they're getting from the US that they can more than fund all their research. Like Humira, which is a big drug that I think is for rheumatoid and related diseases. That makes as much money as some countries' total drug budgets.
Wow.
Oregon would have to then step up to the plate under our universal plan and directly negotiate with the pharmacies. And if you want to go one step further, Oregon would have to have its own, should also have its own pharmacies.
Yeah, so just to back all this up, recalling T.R. Reid's Sick Around the World, you're mentioning the pharmacists and for Pfizer in Switzerland. So Pfizer has a big plant in Switzerland, and T.R. Reid is speaking to the I believe it was the president of Switzerland, or whatever they call their lead government person. And TR says, well, I mean, how do you control the price of drugs? And he said, well, the president says, well, let me tell you a story. So Pfizer came to us, they have a big plant here in Switzerland. And they said, if you don't pay this amount of money for the drugs, we're going to leave Switzerland. And the president said, okay, leave, we'll buy our drugs from Germany.
This is Larry. So what's the way out of this? The single payer plan? And is the one that is currently in going through the legislative processes, is it address this?
Well, not directly, but instead of having, you know, say Medicare Advantage plans, they have multiple plans in each state, and there are multiple ones of those. It's so much more complicated that it's not even efficient for the insurance companies necessarily to be trying to address this directly with pharmaceutical companies, because they have so many different ways they're selling drugs to their patients. I mean, they're not trying to necessarily sell drugs to the patients the most cheaply. They're trying to make the most money, and the only way they're incentivized to try to sell it cheaply to patients is if by you getting a better deal and them paying less for the drug overall, they can make more money. So potentially they can charge you less money and they can make more money, but that's their incentive. I mean, insurance companies aren't in business to provide you health care cheaply.
Mike?
Yeah. Oh, I'm off screen. Can you hear me, Sandy? Can you hear me? So Sam Metz is fond of saying, single payer will not solve. He goes to quite a list. The workforce shortage, the pharmaceutical prices, dishonesty, greed. It will not solve any of those. But when you do have it, you have a mechanism to start solving those problems because you have economy of scale, you have power to negotiate. So when people ask you, it's going to solve all those problems? No, but it's the best start to do it.
Yeah, if I could offer another quote from Sam Metz. Single payer is the only system that provides better care for more people at less cost without shorting the providers.
But is there not a way with the single payer plan to get rid of these organizations with these letters that I can't remember?
Well, so it would seem to me, at least, maybe we have other people in the room that could help answer this, but it would seem to me that getting the governing board up and running, this would be one of the areas that the governing board would actually be addressing is the cost of prescription medications. I mean, that just seems like an essential governance issue.
Well, I guess that's what makes sense to me. You know, if we have a single payer plan that is setting up the way healthcare will be conducted, can't they have their own negotiating board or whatever to do this and get rid of these others?
And that's an issue, I guess, as it's being discussed in committees and not in the public meetings and committees, but the task force, it suggested, I think, a board with 7 paid members, 9 paid members. And should there be paid members, you know, doing this? And I've been doing some research on this. I haven't got all the way through it yet. Oregon does have 7 commissions where the members are paid. And one of them is tourism and development. So what I'm suspecting as I look at the other 7 or the other 6 boards besides tourism and development, they're looking at ways that are saving the people of Oregon money net. You know, like tourism and development. So if you got a 9-member board or a 7-member board and you're paying them and they're doing real work, but it's bringing in money to Oregon, then it's potentially lowering the taxes, for example. So I would be strongly in favor of having competent people doing this work. So they could be, you know, working on ways to negotiate contracts directly with manufacturers and looking at other models that are working, but always with the sense of trying to get the same or better care cheaper. But I myself, this is getting off pharmacy a little bit. Single payer by itself, other than covering everybody, it's not set up for what the task force is recommending for better models of care. What single payer is doing at present is it's using one payer to pay for all the current models of delivery. So there's also a lot of potential for other ways to get better care and other ways to get better care more cheaply.
Larry, did we answer your question?
Probably as well as you can.
I appreciate that, Larry.
Yeah, well, you hinted at something that I've been talking about ever since I've been listening to this whole healthcare thing for the last 20, 25 years in Oregon. And that is that any kind of payer plan is not going to just solve the problem, because how you do things at the ground level, how you administer care, how you that's what is really needs to be watched. And I think Oregon has made a lot of progress in that in the last 20 years. But it still is sort of bottom line. You can't just say, well, let's have Medicare for all if the system is not a good system that you're running. So we have to look at all the different kinds of system improvement and that sort of thing, as well as how you pay for things. But I would like to think that we could do them all together in a productive sort of way.
I'm with you on that.
I'm off screen also. This is Mike Huntington, and we are making some steps that would prepare the way for a single payer plan. One of them is the, you'll have to help me, the name of the drug commission that was established by the legislature last year to decide which drugs are actually worth paying for and what ones we should actually pay for. And Senator Patterson got a full page ad in the Oregonian against this by the drug industry, because of course that's where they get their the ad was showed the picture of the Capitol in the background, and then don't let the legislature take away the latest vaccines from you. That's the kind of advertising that they use. But they do have the commission, and I don't know how it's functioning. If anybody else does, please do chime in.
We need Mike if you want to.
Yeah, I think that's different. I think that's looking at what drugs feed into a good care regimen. And I think all the state Medicaid plans have always had what drugs they're going to pay for and what drugs they're not. I mean, a big one with Medicare is some of the newly developed drugs that ostensibly help with Alzheimer's, but most of the economic evaluation groups, which they do exist, say it's not a good one, because the research on how effective it's likely to be and the whole mechanism for how it might be effective, it's not good research, and it would cost a ton of money, like something like $40,000 per person per year. And it's like any plan we have, there's not enough money to do everything for everybody forever. And there has to always be groups of people that are deciding what fits in and what doesn't.
I have some thoughts.
There's the Oregon Affordability Review Board and the Oregon Prescription Drug Monitoring.
Somebody was saying they.
Yeah, someone spoke up. Can you?
Yeah, it's Cheryl. Can
Okay.
you hear me?
Yes, we can.
Awesome. Hello. A few thoughts and some kind of wrap to what Larry was saying too. So number one, there's an ad going on right now about, and I'll have to pay attention to it better next time it comes on, but it's about PBMs and talk to your, right. Anyway, I'll pay attention more, but there's that going on. So, and what Larry was saying about, is it a good thing or bad thing to have these guys? My thinking is we can't solve these bigger things until we see them, the transparency, right? So the more complicated something is, we don't have a chance in heck to solve it, right? So pushing for that universal health care, getting the governments to negotiate directly with the pharmaceuticals and all that, that's a step in the right direction to be able to solve all those other issues. The other side thought I have about this is, the more I'm actually going to be writing President Biden about this. Yay, that he's on the front ends of saying, you will not destroy Medicare, right? But we know with the REACH program, that's just undermining Medicare, Medicaid, and all that. And so I'm kind of seeing the same thing with these PBMs, that, it's probably not a spoken thing, but it is a step towards privatization, which will be the end of Medicare and all these services, etc. That's just some thoughts I've had.
Agreed.
So I'm writing President Biden a letter about that. Say, okay, then you got to take care of REACH, and now I'm going to add PBM onto it.
Yeah.
Well, my soapbox thinking here is that the problem underlying the whole thing is the idea of medicine for profit on the open market is incompatible with a caring, productive, affordable healthcare available to everybody.
Absolutely. Got to get the profit out of it.
Yeah.
And that's another thought, is that when we do switch to healthcare for all, we will become more interested in healthcare.
Yeah.
I mean, I'm a physician, retired physician myself, but when I went through medical school many, many years ago, you could actually afford it.
Right.
I was a poor boy off the farm, and I finished medical school and 5 years of residency plus internship, and had 6 children when I finished, and I didn't have any debts.
Wow.
And my father and relatives put no money into it. Now look at what it costs to get an education. And so I think that people that work in the healthcare field that invest a lot of money and so forth do have a right to a good income that allows them to, or else, have some way of paying for their expenses so that they don't have to go into the super specialties and have the huge fees in order to make a living, in order to make a decent living. But neither do we need to end up becoming multimillionaires by doing that. And I think that's true of the whole healthcare thing that I'm talking about, where you can set your price depending on the competition and how valuable you are in terms of what you can make, rather than how valuable you are in terms of what you contribute. And anyway, I said I get on a soapbox and I stayed pretty long, but I'll get off now.
I wanted to go back to the comment Cheryl made about the business end of things. One of the first meetings of MVHCA that I ever went to was a program with 3 doctors, and one was a neurologist. And she said, and this is part of what got me involved with MVHCA. She said, here's why medicine, healthcare does not work as a business. It's because when somebody is per business to be done well is partly dependent on people being good consumers and really thinking about what their options are and their choices are and checking them out. And she said, if I'm working with somebody who's in terrible pain or terrible illness, and I tell them to go see so-and-so, they just do it. They do not check out any options or any other possible caretakers or care providers. If I tell them to use a certain drug, they just do it because they're so desperate to get out of pain. And so it doesn't work as a business because we don't have good consumers. And I thought, oh boy. and between that and Betty Johnson, I became a member of this group. Let's see, I think I saw Marisa Bell's hand go up. You'll need to unmute yourself.
Yeah. So I have to say that I admire all of you because you just keep discussing this and going back and forth. The whole thing is so illogical, and it's hard for me not to curse, quite frankly. It's really hard. And I think, wow, these Americans are impressive, how they just talk about if we do this and we do the other thing. I'm a pacifist, but damn it all, I want to pick up a gun. This is so horrible. This is for profit. This has nothing to do with caring for humanity or the nation. Is this how the Roman Empire finally fell? Is this how empires finally fall, that the greed becomes so great that they don't care about the massive population and how they have nothing? Because as long as they have their house and their car and this and that and the other thing, and that it changes obviously through the centuries, that there weren't cars, etc. But the greed is so excessive. You know, I was in Cuba in December, and healthcare is free in the most incredibly poor country in the world. And they're developing medications and all sorts of stuff that now even the United States is beginning to use. My God, I despair. I despair. And I admire your patience in trying to find your way through this labyrinth, which is intentionally put there so that you cannot find your way out. You can't find your way out. You know, Bruce, I don't know how many times I should have recorded it that you said this is so confusing. Well, it's intentionally confusing so that nobody can find their way out and they just despair. You know, I just got the diagnosis of cancer, and my first thought was, I won't survive, not because of the cancer, but because it'll take my house and my car and the little finances I have, and I'll be absolutely broke. And then I said, oh, just leave the bloody country. Nobody wants a colored woman here anyway. So just go someplace. What a disaster we're in. Really, I admire you that you can talk about it, because I'm sitting here thinking, hide under a blanket. It's the only hope here, is to hide under a blanket. I don't know what to do. I despair. But I'm also not very mature, because if I was mature, I would just talk about it.
Well, Marisa, I despair too, except that I talked earlier about the single payer plan and what we are working at. I haven't kept up with that as well as I should have, so I don't really know exactly what's going on. But it just seems to me somehow that we have the will and the way now to do something about this and to get rid of these money grabbing intermediary agencies or whatever. Maybe I'm naive in thinking that that's possible, but aren't we kind of making headway in that direction?
I think so, but I'm too old now. You know, I'm never going to see this.
Member of the legislative committee here, let's hear from you.
Marissa Bell, you know that you're not as old as I am.
Oh, God. So I'm sorry to take up time and just, I do despair.
So Alex, you got a comment?
Well, he's actually we're gonna have reports.
Oh.
And you'll get, you mind waiting for that? No, I don't mind waiting. Okay.
In saying that I despair, I don't mean that we should give up, not by any means. You're so calm and collected, and I think I have to learn how to use a gun or something. I don't know.
Under this calm demeanor of everybody at this table, believe me, there is a seething, wrenching angst. Karen Nellis wants to get in.
I want to share my experience. I'm a dietitian, and I started in the early 70s. And at that time, our organization wasn't taking money from Coca-Cola. But I just see a different world now. I went to Nebraska, I had a stipend. I didn't have any debt when I started my career. But then when we were planning conferences, we used to pay money and that would cover the conference. But then we started taking money from big corporations, and then they would tell our speakers what they could talk about. And so we had this speaker at a conference for education, and she was talking about having a farm and doing food correctly. And this guy that was paying for our conferences, she can't say that. And it's like not the world I want to live in. I want to eat healthy. I don't want these big corporations telling us what to do. I don't want the American Dietetic Association to take money from Coca-Cola, because all it is sugar, empty calories. So there's my bandwagon. Sorry.
Let's see, soon we need to move on, but is there any last question or comment from anyone? And then we'll go to reports. Alex? It's gonna come around.
Oh, hey, Marissa Bell. I mean, that's really moving what you said. And all I can say is, you know, I mean, Betty Johnson was who enlisted me in this like 15 years ago or something, you know, and she was the hardest worker of any of us. And she didn't live to see the work continue, but she knew it would. And you know, Mark Betts was really integral to a lot of our legislative work, and he's passed on now. And, you know, I mean, I think all I can say is speak for myself. I mean, I don't know that I'll ever see this happen either, for sure. But I mean, all you can do is, you know, personally, I just feel you do what you can, you give as much as you can of the effort, and then, you know, it's kind of out of your hands past that. But you can, you know, you can be committed to it, and, you know, and it may not be us, it may be those others, you know, following behind us to carry it on. But, you know, I mean, I'm not a speaker like, you know, MLK, but, you know, the night before he died, he, you know, he gave that speech about, you know, he's been in the mountain, right? And he knew he really knew in his heart he wouldn't get there with everybody, but that it would happen eventually. So, I mean, I don't know if that's any help at all, but, you know, I mean, I feel like we're all doing the best we can, and, you know, under the circumstances, and the work continues. And, you know, I'm gonna keep at it, and hopefully you will, and everybody else will too. So.
Thank you very much for that. Thank you very, very, very much for that.
And just a quick comment I'll share. When I went to my first rally at the Capitol steps, I forget what senator or rep it was, but he said to the crowd, because somebody asked the question, like, we don't have enough money to be donating to make this happen. You know, we're all up against the lobbyists and the big dollars and all that. And he said, if there's 1,000 of you out on the Capitol steps and only one of them in my office, I'm listening to you because you're my paycheck. keep showing up is what he said. And that is why I do this. I mean, you haven't seen me physically with you guys, but I'm talking about this all the time. And it will happen, and it's just a critical mass across the states that's going to happen. But I do think it's going to happen state by state by state, and we're really close in Oregon. I'm really proud.
So do either of you guys want to make a last comment of any sort? Any, okay. I'm going to move us on, and we will have some reports, and since he's sitting right here across the table, we'll have the legislative committee with a report from Alex.
Thanks, Mark. Can everybody hear me okay? So it's very timely, this conversation on PBMs. David already kind of alluded to this, but there is legislation. There's actually several bills, I think probably 5 or 6 of them relating to PBMs. And it was also appropriate, Bruce commenting on how opaque they are, because a lot of them deal with taking away some of the mask of the whole process and making it more transparent. So in the legislative committee, we're following some of those. The main thing we're following is what everybody's concerned about, is the single payer legislation that came out of the task force, the SB 770 task force. So Senate Bill 704 is the Senate bill that was sponsored by Senator Manning and has a companion bill in the House. It's House Bill 2558. And those bills would establish a governance board, which is what the task force recommended. And it's really the first step. Again, David was just mentioning that previously. So that's really the first step. The governance board would really be responsible for hashing out how the single payer would be implemented here in Oregon. So there have been 2 public hearings. There was a public hearing on February 13th. That was actually carried over to the 15th because there were so many people wanting to testify. And that was really the heartening thing. There were hundreds of people who submitted testimony, including quite a number of Mid-Valley members. And of all the testimony, there were hundreds of people testifying in support of, and there was maybe a couple of dozen of people opposed. With of course your normal health insurance and health underwriters, saying don't do this because it's going to impact their incomes. But a lot of people testifying for it. And our own Mike Huntington testified on February 15th, did a fantastic job. Is that on the website, that video?
I'll send all 5 of those out to everybody.
Okay, yeah, he's going to be sending out just a snippet of maybe about 10 minutes of testimony during that hearing. So anyway, it was really great. That was a public hearing. Then there was a work session scheduled where this was in the Senate Committee on Healthcare, where the committee would work that out, but that was postponed. And so the postponement had to do with some reservations about what the original bill was and what the amendments should be, because there's an amendment being worked on it right now. And so that work session was postponed, and then it was postponed again. So, all I can tell you right now is there's conversations going on with the parties involved, with Senator Manning and Travis Nelson, who's the sponsor in the House, and then with HCAO and some Mid-Valley members. So there are amendments being worked on, actually trying to make it more palatable. David mentioned some conversations about whether the board should be paid or not. And with legislature, money is always a big issue. So I think that's really kind of what's rearing its head, is what will the legislatures feel like they can, what can get through the committee, especially when it goes to Ways and Means, which is next, because Ways and Means, they hold the purse strings. So there's conversations going on now, and we'll just have, again, I'll just keep you updated on all that. But the whole idea is, how do we get this through? How do we get it out of healthcare to Ways and Means, and get it out of Ways and Means so that it can go to the floor and actually get voted on? So that's where all the efforts are now. If we need, when it gets to Ways and Means, we may ask you, the advocates, to become advocates again and submit testimony and email representatives. So we'll let you know when that time comes for that lobbying effort.
Just a quick. So, yeah, I think this afternoon, just a notice that, on Thursday, so this, March 2nd, that there's a meeting with Senator Manning and Representative Nelson. The time has not been finalized, and who all will be participating in that meeting is not known at this point. So just to say that will be happening.
You know, I forgot to say thank you to David and Bruce for doing this program, and it's been very enlightening and certainly stimulating. We've really had a lot of discussion because of this. So thank you guys very much.
And enraging.
And enraging, yes, well. The whole thing's enraging. Okay, let's see here. Let's hear from the Finance Committee. Kathy, do you have anything you want to share tonight?
Yes, we're in the midst of preparing the spring fundraising letter, so we'll have more money to accomplish things with, and just one, and everybody helps and does a great job on that. I so appreciate the people on our committee, which Karen Nellis and I got together today to work on some things that are just to make numbers, make a picture out of the numbers that we have. So we'll share that when we have something done. The other thing I wanted to say, this is anecdotal, but Marissa Bell, if I could give you a hug right now, I would. So virtual hug to you. But you know, and we talked about Switzerland earlier in the meeting. So I have a bunch of relatives in Canada. My daughter lives in Switzerland. Us and Canada and Switzerland, we're all capitalist countries, but we have different priorities. And that determines how money gets spent. And so the thing is, we're different, but they have managed to figure out ways to prioritize people's health over a long list of other things. And I love the US, but like it can be frustrating. So like a bunch of people have said this evening, we just have to keep putting one foot in front of the other and we'll get there. So that's the end of my finance report.
Thank you. And when my wife had cancer, that's what she said about herself. I'm just going to keep putting one foot in front of the other till this whole damn thing is over. Let's see. I don't know if there's anybody here from, oh, Karen Christensen has a hand up.
Thanks, Mark. I just wanted to remind people that the League of Women Voters is having a legislative update on Saturday. It's the first Saturday of every month during the legislative session from 10 to 11:30 at the Corvallis Library. And that's an opportunity once again to put ourselves in front of our representatives, Sarah Gelser, Roger Davis, Stan Rayfield, and David Gomberg. So it's important, I think, to go to these informal sessions as well as having our direct contact. So if you could please make 10 to 11:30 at the Corvallis Library. Thanks, Mark.
Thank you. All right. Is there anyone from the outreach committee here tonight? I'm not sure that there is. Who would want to give a report? Mike?
Yeah, I think the outreach committee is making a great deal of headway with social media. Simon Hutton is working with Fritz, primarily the two of them and myself, to get a frequent presence on Facebook and on Instagram. Simon is very skilled at this and also even creating Canva posters. So he's busy doing that. He's about to open the new website. It's still Mid-Valley, but it's an upgrade on the system, Squarespace. So look for that in the next few days. Let's see what else. Well, we have Sustainability Coalition meeting coming up. Anybody remember the date on that?
The town hall?
No, there's a Sustainability Coalition meeting on that's coming in March on a Thursday. So we'll make sure everybody gets the notice of that to come table, and that we'll share a table with the League of Women Voters at that. So let's see what else. Anything else, Mark? So what I've forgotten, we'll send out in the summary of our meeting tonight.
Okay, let's see. Let's go to officer reports and treasurer. Karen, do you have anything you want to share?
No.
Okay, that was quick. Secretary Sandy, do you have anything you want to share?
I'm just taking the minutes and carrying on with that. Nothing else to report.
Mike as vice chair, he's going to come around the table again.
Couple of things. I just saw Francis Johnson yesterday. He's at the Caring Place. He had a stroke in November 1st and lost vision in his right eye. He gets around with a motorized wheelchair. He's sharp. He goes shopping at Fedmeyer. So that's one on Francis. Makes me, of course, think of Betty Johnson. And she drilled into us that we have to replace ourselves. We got Mark Bentz at a farmer's market, stopped by. We know how we got Kathy Soward. We got a bookmark on her door after she had been through a very frightening episode with an illness and realized that had she not had insurance, she would have gone home and not gotten the proper care. So coming up, we're going to have now more opportunities to interact with the public. And we have to decide how we're going to do that. Do we want to do farmers market some more? Or do we want to sort of crowdsource, go to events where people are waiting in line and ask them to sign up with us or hand out literature? So we have to be inventive on how we're going to replace ourselves. And canvassing will be coming up again too. So keep thinking of this and think of people you would invite who are waiting for your call. They don't know about us, and yet they want to help. And they've had kids and their parents who have suffered because of our healthcare system. They're waiting for your call. So when you get the notice that we're going to have a town hall or a rally, think of who you would want to bring along. They're all fun. They're tedious sometimes, but usually fun. I never regret going to farmers market because I always come away with an experience that's memorable and leads to a next good event. So that's my pep talk for the coming active season of interacting with our replacement.
All right. Yes, Alex has another comment.
I just wanted to add, since Karen reminded me about she was talking about that legislative town hall on Saturday. So after Senate Bill 704 gets out of healthcare, it's going to Ways and Means, and Sarah Gelser is on Ways and Means. So if you are at a legislative town hall, or even in the grocery store and run into Sarah, you might mention something about 704 coming up and how you would like to see that get out of Ways and Means. So I just wanted to let you know about that.
For anybody interacting with any of your senators or your representative, we can't let them go, oh, we can't afford it. We can't think of this as just a cost. The whole point is that there was an actuarial firm retained with the task force that demonstrated it was going to save money. And, you know, so if you just look at it as a cost, oh my God, you know, it's going to be $5 million or it's going to be $10 million or something. But it's supposed to save like,
That's conservative.
yeah, $1 billion over 10 years, I think, right?
No, that was per annum.
$1 billion per year. So, you know, they have to look at it that way, even if it's a risk. And when are we going to have more money than we have right now? If that's the other thing. You know, it's a thing that the actuaries say it will save money. And we're not going to, probably in the future, we're not going to be so much more well off than we are presently.
Thank you, David. Those are some good points. Let's see. For President's report, I'll just be very brief. I know we're pretty much out of time here. So mostly thank you to David and Bruce for speaking tonight. If you have ideas about speakers for future meetings, or if you'd like to be a speaker at a future meeting, please let me know. I'll just say the cost of higher education came up around the cost of going to medical school, but really the cost of higher ed has just been screamingly increasing. Right along, students now pay more for 1 credit than I ever paid for an entire term at a university. That's students at a community college pay more for 1 credit than I paid for an entire term at a university. As an example, there are 3 really clear reasons for the rise in cost. And if anybody, I won't go into a whole lecture here, but if anybody wants to hear about that, I've done a fair amount of reading up about this, and there are some really good investigative reports from the Atlantic Monthly and from Forbes magazine that I've used. In any case, I'd be happy to respond to anybody who wants to email me, mjweiss@cmug.com. And I think my email is probably on the website. And then lastly, we're organizing a benefit concert for Mid-Valley. And you might want to just jot the date down on your calendar, May 26th. We'll raise a little extra money. Benefit concerts never raise a ton of money, but we'll raise some. And if everybody shows up and brings a friend, we'll raise more. So please come. And thank you all for being here. This was a very controversial and enlightening and invigorating meeting. And I appreciate everyone's work. It's great to be working with you. Thanks. And good night.
Thanks, Mark.
Good night. Good luck.